Test 1, 2. Hi, it's Doug Smith again. In this video, I hope to explain how I came to my current perspective on the physiologic pain response and its importance in maximizing tissue health and healing, as well as its relevance to the opioid epidemic. Now, in 2001, about over 15 years ago, the U.S. Congress inaugurated the Decade of Pain Treatment, and the Joint Commission established new standards that enshrined pain as the fifth vital sign. Over the next decade and a half, the advice and opinions of pain experts were that pain is a serious and common clinical problem, that pain can be safely managed using opioid drugs, and that it is inhumane to withhold opioid analgesia from people who are needlessly suffering in pain. Yet the facts on the ground over this time period have raised doubts in these mainstream beliefs about pain. For the past 15 years, there has been a steady stream of reports showing worse health outcomes, skyrocketing costs, addiction, ruined lives, and chronic debilitating pain despite high-dose opioids. This has begun to call into question standards of care regarding the risks and benefits of opioid-based pain management, as well as our understanding of pain itself. In the face of this growing disconnect between expert medical opinions on the one hand and frontline community experiences on the other, the official response was denial and advice to stay the course. When this failed, there were efforts to blame the crisis on a few addicts breaking their treatment contracts. And finally, more recently, there have been recommendations for better training and research into pain and pain management. However, these have been primarily limited to better use of opioids. The Institute of Medicine established a committee on advancing pain research to review the situation, and according to their report, over 100 million U.S. adults have developed chronic pain with our current approaches, and this has cost over $635 billion annually in medical care and lost productivity. That's over $500 billion a year. The committee's primary conclusion was that, quote, addressing the nation's enormous burden of pain will require a cultural transformation in the way pain is understood, assessed, and treated, unquote. It is with hopes of catalyzing such transformation that I share with you in this coming videos key perspectives that have been missing from the mainstream pain literature, medical education, and clinical practice. These missing factors include an empirical understanding of the physiology of the pain response, a critique of the popular view of pain as pathology, and a clinical appreciation for why treating, quote unquote, treating acute and chronic physiologic pain with opioids is often harmful and counterproductive. In the tradition of American pragmatism, these common sense perspectives suggest a new path for medical research and education into truly safe and cost-effective pain management. Furthermore, these perspectives may be crucial to ending practice standards that have created the current opioid epidemic. But before explaining this in detail, let me briefly share the background on how I arrived at these perspectives on pain. As a psychiatric physician, I have been concerned about the dramatic increase in the long-term medical use of prescription opioid drugs. Over the years, I have repeatedly witnessed the abnormal clinical signs and symptoms that are often associated with long-term opioid use, including the deterioration in mental and physical health and suffering from addiction. But it was usually more than just addiction. Despite higher doses of opioids, these unfortunate patients experienced repeated periods of uncontrollable pain each day. They lived on an opioid roller coaster, careening between underreacting and overreacting to ever-worsening health problems. They showed multiple signs of progressive tissue damage, particularly in their joints, along with disrupted sleep, depressed mood, social isolation, and physical inactivity. I struggled to help these patients, several of whom eventually died from overdose. For long-term users of opioids, I observed a pattern in which the artificial relief of pain and discomfort from initial injury had caused an insidious slide into far greater suffering. And this pattern is the tragic irony of prescribing opioids to manage pain. The more we've used prescription opioids and the higher the doses, the more likely our bodies are to fall apart with recurrent injuries, muscle aches and strain, inflammation, dental problems, headaches, infections, and premature osteoarthritis. Any doctor with their eyes and ears open has been aware of this growing opioid epidemic, as well as the clinical problems caused by artificially blocking pain with opioids. I have also been blessed to witness the process of recovery and tissue healing. Our bodies have remarkable and indispensable capacities for repairing and rejuvenating our cells and our tissues. And while opioids appear to undermine these capacities, in most cases this is readily reversible. I have been consistently impressed by the improvement in patients' pain regulation as well as their overall health following proper opioid detoxification, including improvement in the status of chronic injuries and tissue inflammation. In talking with patients and colleagues about both conventional and alternative approaches to pain, and in trying to keep abreast of the medical literature and the popular reporting on the topic, it has appeared that something important has been missing in our understanding of pain. Clinicians have begun to recognize the benefits of alternatives to artificially blocking pain, but they have had difficulty articulating a coherent biomedical explanation for why the mainstream advice from pain experts has been so wrong. Like many in our country, my personal life has been damaged by the crisis in pain management and opioid addiction. At the start of my medical career nearly 20 years ago, a gifted artist and a lifelong friend was hit by a car while he was out jogging. He went to the emergency room and was seen by his primary doctor and put on an extended course of hydrocodone for soft tissue injuries and for lingering pain. He soon became addicted to prescription opioids, and his life was never the same. In April 2015, he died of an unintentional opioid overdose, leaving a grieving family and a 5-year-old daughter. This story is just one of tens of thousands across the country. My clinical and personal experiences have caused me to doubt the conventional clinical view of pain as pathology and the belief in the general benefits of analgesia. On both a personal and a professional level, I realize how important it is for American physicians to begin doing better with pain management, and I understand what is at stake here. But the nagging question remains, how can we do this? What have we been missing? It is with these doubts and questions in mind that I came across the remarkable work of Dr. Paul Brand. Brand was a surgeon who made detailed clinical observations about the physiology of the pain response across his life, which was dedicated to treating those with injuries caused by insensitivity to pain. He spent the last 20 years of his practice working for the United States Public Health Service as chief of the rehabilitation branch at the National Hansen's Disease Center in Carville, Louisiana, where he established a well-equipped and well-staffed clinical research unit. Over his long career, Dr. Brand carefully observed how pain sensation and insensitivity affected his patients' behavior and psychology, and how this impacted their tissue health and healing. His insights and techniques are still used by podiatrists to improve care and treatment of the diabetic foot. Now I'd like to read from Dr. Brand's book, Pain, the Gift Nobody Wants, to give you a sense for his perspective. This is from the introduction. My thoughts about pain developed over many years as I worked with people who suffered from pain and who suffered from the lack of pain. I have chosen the form of a memoir with all its loops and detours, for that is how I learned about pain, not systematically, but experientially. Pain does not occur in the abstract. No sensation is more personal. The scenes I will relate from my early life, random and seemingly disconnected like all memories of early life, eventually contributed to a whole new outlook. I readily admit that my years of working among the pain-deprived people have given me a skewed perspective. I now regard pain as one of the most remarkable design features of the human body. And if I could choose one gift for my leprosy patients, it would be the gift of pain. In fact, a team of scientists I directed spent more than $1 million in attempting to design an artificial pain system. We abandoned the project when it became abundantly clear that we could not possibly duplicate the sophisticated engineering system that protects a healthy human being. Few experiences in life are more universal than pain, which flows like lava beneath the crust of daily life. We know well the typical attitude towards pain, especially in Western societies. J.K. Husmans calls it the useless, unjust, incomprehensible, inept abomination that is physical pain. Neurologist Russell Martin adds, pain is greedy, boorish, meanly debilitating. It is cruel and calamitous, and often constant, and as its Latin root poena implies, it is the corporal punishment each of us ultimately suffers for being alive. I have heard similar complaints from my patients. My own encounters with pain, though, as well as the specter of painlessness, have produced in me an attitude of wonder and appreciation. I do not desire and cannot even imagine a life without pain. For that reason, I accept the challenge of trying to restore balance to how we think about pain. For good and for ill, the human species has among its privileges the preeminence of pain. We have the ability to step outside ourselves and self-reflect by reading a book about pain, for example, or by summoning up the memory of a terrifying ordeal. Some pains, the pain of grief or emotional trauma, have no physical stimulus whatever. They are states of mind, concocted by the alchemy of the brain. These feats of consciousness make it possible for the suffering to loiter in the mind long after the body's need for it has passed. Yet they also give us the potential to attain an outlook that will change the very landscape of the pain experience. We can learn to cope and even to triumph. Now, Brand's quest for a more clinically meaningful perspective on the physiology of pain brought my personal and clinical experiences with pain into sharp alignment with a new understanding of brain and behavior, and it opened my eyes to a better approach to pain management, one that supports rather than undermines the body's precious capacity to prevent injury and promote tissue repair. It has become apparent to me that a normal pain response is crucial to maintaining healthy tissues, particularly against damage from the continuous and inescapable threats of weight-bearing ischemia and excessive muscle-generated forces. From this perspective, it is easy to see why the long-term use of opioid analgesia has not been an effective strategy for managing pain. Unfortunately, we find little evidence of Brand's rich understanding of the beneficial pain response in contemporary information sources, including medical journals, textbooks, expert guidelines, consumer websites, nursing standards, government policy and research agendas, and even the curriculum materials used to train and certify physicians who specialize in pain management. If there is any mention of this positive perspective on pain, it is typically a perfunctory mention that pain protects tissues. Often this amounts to a sentence or two in an introductory paragraph to a chapter on pain physiology. One example repeated from one source to the next is that the only reason for pain is to compel us to withdraw our hand if we step on a tack, if we touch a hot stove, or withdraw our foot if we step on a tack. This understanding of pain is little advanced from that of René Descartes 4 centuries ago. Beyond such crude illustrations, little else is said about the physiologic role of pain in contemporary textbooks. The bulk of clinical teaching and research are devoted to pathologic pain, to the complicated neuroanatomy and neurochemistry of pain pathways, and to techniques for interfering with pain sensation. It is clear to me that medical, education, research, and standards of care have been shaped by the questionable belief that for most patients in pain, pain itself is a problem that should be eliminated. Current medical education initiatives are focused on teaching doctors how to safely relieve discomfort from pain by being more conscientious in the prescribing of opioid-based systemic analgesia. And pain research is primarily focused on finding new drugs and other therapies to artificially block pain, advising us to do the same, just try to do it better. Pain experts have clung to artificial analgesia like a life preserver in a sea of suffering. This has not worked. Perhaps it is time we let go. Any transformation, any true transformation in the way pain is understood, assessed, and treated will require a paradigm shift away from the current misguided view that pain is generally pathologic, and toward the recognition that pain is usually physiologic and beneficial. This shift in perspective offers us a coherent biomedical framework for sustainable improvements in the care and treatment of most acute and chronic pain conditions, with less reliance on opioids, more effective primary prevention of opioid addiction, and reduced healthcare demands and social costs. It is my hope that you will review Brand's observations in the coming videos and his insights into the physiology of pain, and will give them consideration, and will share those that you find meaningful. The main lesson that I wish I had been able to share with my dear friend 20 years ago when it could have possibly saved him is that pain is not an enemy. Pain is our body's indispensable ally for tissue health and healing. We should let it be our guide.